I want to ask you all a question. Do you remember when Jenna was talking about how she had to pivot during a presentation to physicians? Right. So before we can even get really deep on the interventions that we know would help moms, especially with Anne's last point, her answer to that question, she saved a mom's life just by knowing that the inability to release colostrum was an indication that there was something significant going on. How many of us would say, before hearing that today, that that would be even something remotely that even we could do which within our scope of practice, right? Like, that's pretty incredible, right? And so Jenna's giving this presentation. We had worked actually on the presentation together, which is why I wanted the copy when she didn't use it, right? I mean, that was a lot of work. When she was given 15 minutes, you all remember how much time she actually was given at the end of their talk? 5 minutes. And do you remember what their biggest pet peeve was? Like, what they were really engaged in, probably frustrated in, what was going on with the perinatal population? Readmissions to the ED, right? And it was readmissions to an ED that was general ED. It wasn't their OB ED, because that was closed down still from COVID. And so Jenna's presentation was not about ED, but she was an ED trained therapist. And she had seen these patients in the ED herself. And so she was able to pivot and get their focus on what she would be doing in the ED to also help triage this patient population. And there was one person in the audience in particular that was absolutely engaged, zoned in on Jenna. And Jenna caught her attention, an OBGYN, just in the hall one day, because the OBGYN recognized Jenna from her presentation. Things weren't really off the ground just yet. Give it about maybe within the first few weeks after that presentation. And that Jenna wanted, or the OBGYN who saw Jenna in the hallway wanted to sit down at the nurse's station and ask Jenna questions. Did you also see maybe women after hysterectomy? Jenna had that experience. She did treat women after hysterectomy within 24 hours of their birth, or after their surgery. A hysterectomy, not cesarean hysterectomy, just general gynecological surgery. Within a few months, Jenna was able to get automatic orders for not only the C-section population, but from this one surgeon, her hysterectomy patients as well. And within that 3-month time, she built a team of therapists that included a new grad PT to see all of those automatic orders that she also got from C-section. And if you recall me ever talking about the program that we were building together, it took us 6 months. If I'm to be honest, it took a lot longer than that, just with the in-services that we did. But Jenna was able to build that team and that program within 3. And so the ability to actually meet people where they are, at that time it was OBGYNs concerned about the ED, is not just a hallmark sign of just you being able to adapt and you just kind of being able to see what the necessary need is. As a therapist, we have that. We should be able to do that with people. If we walk into a room and the family clearly was fighting about something, we kind of adapt our energy. If we walk into a room where mom actually lost her baby, or the baby passed in the NICU and maybe it hadn't reached the chart, and you find out that information, you're going to pivot. It's the ability to also see where you are in the context of the setting, right, that you work for. Is that, yes, your patients are number one priority, but your patients, someone said, is also the hospital system. Your patients are the hospital system. And the person who said that is Dr. Rebekah Griffith. She is the founder of the EDDPT. She is the president of the Colorado State Association of the American Physical Therapy Association. And she's also an international speaker and was just hired by the Turkish Physiotherapy Association to train their providers to work as physical therapists in the emergency department. I'm so honored to have her speak with you today as our last speaker of this course, because one of the major questions that we also get dinged on as a training organization is, what are the financial benefits to your institution other than, or otherwise known as, your patients? You're serving a whole system of people, of their families, of the providers you work with, and of the system to make it function and sustainable. I couldn't think of another person who would be better to deliver this answer that we all are looking for than Dr. Rebekah Griffith.
Well, I'm Rebekah Griffith. It's so nice to be with all of you. I'll just spend a brief moment introducing myself because this is like what I would consider not my space, right? I have some credentials to be in this room. I have 3 babies that made it into the world, 1 that didn't, and I have another that found me in this earth and I mother him. So I am a mom. I'm hearing you guys talking about breastfeeding and I'm like, where was this at? You know, I went to the hospital multiple times with mastitis. I've never been sicker in my entire life. 106-degree fever while walking. Wasn't able to continue nursing 2 of my babies because of mastitis. So just thinking about all of those things. And then I used to teach this like brief course for women called Wellness While Expecting. And I would say, you want to not neglect what you need because you don't want to be in the worst physical shape of your life when you're going into the most physically demanding event of your life. So I want to acknowledge all of you for being in this room and for really transforming care. And one of the vision of the APTA, right, is to transform society through optimizing movement. And I get really like emotional thinking about that because what a privilege that we get to do that. And when I talk to my kids about what I do as a physical therapist, they're like, why do you have to know all this stuff? Well, because if we're going to truly be accountable for somebody's movement, which body system does that include? It includes all of them, right? So by background, I like to think of myself as an all-patient therapist. I'm board-certified neurologic clinical specialist, and I just finished my fellowship in orthopedic manual physical therapy. That was a pandemic purchase. Next time we have a pandemic, stick to sourdough puppies. Like getting a fellowship is maybe just not where you want to go. I definitely would have told you I regretted it until I finished it. And then I was like, oh yeah, we've got to move forward. And we're all moving forward in a different way. So congratulations to all of you for being here and moving forward. But the other thing that I want to just call out in this room is we're all women.
That's right.
How amazing is that? I was talking to my bonus baby on the way down here and I said, I bet it's going to be a room full of women. And how amazing will it be for me to be sharing that space? And then I thought to myself, where are the men? And this work isn't done until this room is also full of men, right? So when we think about transforming society and we think about moving into spaces that are new as physical and occupational therapists, how do we do that? How do we know that work is done? And that work isn't done until it's routine and it's a job you just apply for. Till you're in PT school and you're like, I'm going to be a maternal physical therapist. And you see that job posted and you don't even know the scope of the work that it took to get that job just be posted for you. So that's how you'll know when your work is done. But before I share my case study with you, I want to talk a little bit about mindset. And I know I'm talking very fast because I don't have that much time with you, but all of this feels like so important to me. So when we talk about mindset, I don't ever give a presentation without it because a lot of people tell me that I'm a visionary without a plan, and that's okay. But I need to pull you into that space with me so that maybe you can think of what's possible because one of you probably does have the plan. So I like to talk about practicing at the top of our scope. And in order to do that, I feel like I need to define what that means. How many of you have heard the phrase top of license? I hope so. And people are like, gosh, I want to practice at the top of my license. I'm going to invite you to consider that maybe that's the bare minimum. You're legally and ethically bound to practice at the top of your license, right? If you're not doing that, you better have really good malpractice insurance. Do you have to do everything you're licensed to do? No. Should you be capable of it? Probably. Should you know what your standards are and hold every patient encounter to them? 100%. But when we talk about top of scope, it's beyond that, right? Like it's past top of license. Top of scope is your mindset, your skill set, your lived experience, your mission, your attitude, and everything you bring to that patient encounter. It's who you want to be as a therapist. Because when we went to PT school, do you remember what that was like, or OT school, when all you wanted to do was become a therapist? I want you to think that's the therapist you wanted to be. How can you continue to be top of scope? But I have a lot of people say to me, I can't practice at the top of my scope. I'm not allowed to, right? That's your top of facility. So we have 3 different levels. We have top of facility, top of license, and top of scope. And sadly, I'll tell you, top of facility is often even lower than your top of license. For example, here in Colorado, we have one of the most liberal practice acts in the country. I can order any kind of imaging I want to, including EMG. But when I practice in the emergency department, I'm not allowed to do that. It's a facility policy. So when our top of facility and our top of license don't match, we have to advocate within the facility. When our top of license and our top of scope don't match, we have to advocate at the state legislature. When our top of scope is not being met by the other people in the profession, we have to advocate for the profession within the profession. Okay, so we're doing all of that today. But I really want to focus on top of facility a little bit, because all of you are taking this work back to facilities, is my guess. And somebody in here is thinking, this course is amazing, but I can't do any of it. They won't let me. So we have to think beyond that. So where I want you thinking for the rest of this conversation is at top of scope. We'll figure out the rest of it later, okay? So top of license, again, bare minimum. Top of scope, it's a commitment. It's not a destination, it's an evolution, all right? We're gonna figure it out. So I'm gonna share a case with you, because you're like, why are you here? You practice in the emergency department, right? You shouldn't be doing this. But when you practice in the emergency department, you have to be an all-patient therapist, because anything and anyone can walk through the door. Do I need to be able to handle everything that comes forward? I'm not the person getting that patient through their delivery. I'm not the person getting the soccer player back on the field. I'm the person there to help that person at one of the most vulnerable times in their life. So my patient almost didn't come into the ED. There's a few reasons for that. One of them is we tell pregnant women that pain is normal and that it's normal to be clumsy. And my patient was a 32-year-old who was 32 weeks pregnant. She had a 2-year-old son as well, and she had also lost a baby several years prior. And what it said on the track board in the emergency department is fall from bed. So the patient was kind of seen by the OB, seen by the MD, and told that she was stable. Which is great, right? She's stable. They're like, you're fine. This back pain that you're having is normal. People fall. Your center of gravity is off. The baby's fine. You're stable. The goal of the emergency department is for people to leave the emergency department. I get that. And physical therapists, occupational therapists can actually help facilitate that. But this patient was stable, medically stable, but functionally wrecked. So she was not able to stand. She wasn't able to walk. She wasn't able to pick up her son. So cleared from an OB perspective, not able to walk without bracing, not able to pick up that child, okay? Which, as we know, is also a thing when you're 32 weeks pregnant, even just carrying an extra load on top of that. So she was ultimately referred for a PT evaluation for balance because she'd fallen. But because we're doctors practicing at the top of our scope, we're not just going to say, oh, we'll just do a little balance intervention, right? We're going to examine, evaluate, receive our patient exactly where they are. So in taking the history, the first thing she said wasn't my back hurts. It was, I couldn't even reach my phone. I was on the ground and I couldn't even reach my phone. I didn't know what to do. And all I could think was, what if I lose this baby also? I've never felt pain like that before. I've had back pain this whole time, but this was new. In further questioning to her, in how did you fall? Why do you think you fell? Well, I think I stood up too fast and I passed out. I felt like I was going to pass out. I hit the ground. I was told this was a mechanical fall. So if I had done a PT evaluation and treat, like gait training, that's where we're at. But now we know what? That potentially there is another medical issue happening here. And just because a patient's been seen by a physician in the emergency department does not mean there isn't an emergency. It doesn't even mean the emergency's happened yet, right? So first priority, I would encourage you with any patient, but especially in the emergency department, is rule out the worst first. Worst case scenario. And we talk about preeclampsia a lot, but we don't talk about how common it is for women, particularly in the third trimester, to also have syncopal events. And we know physiologically why that happens. So what do you think we have to do first with this patient? Even if we just think about where she's arriving. She's been told she's medically stable and the baby's okay. But she's still coming in this vulnerable place of panic. This is what I call the what if cycle. What if I lose this baby too? What if I can't take care of my son? What if I have this pain forever? What if I can't get comfortable again? What if I pass out again? What if it's worse next time? What if I can't sleep tonight? What if I can't have that vaginal delivery I want to have? All of those things are spiraling while your patient's in intense pain. So the first thing that we have to do for any patient in the emergency department and arguably anywhere else is help that patient regulate before you ask for anything from them or do anything to them. So I usually will take patients through a what is happening, not a what if cycle. What is happening right now is that your baby is safe and so are you. What is happening right now is that your son is being taken care of. What is happening right now is I am the right provider at the right time to assess your back pain, and we're going to make sure that you can at least find a position of comfort before you leave here and we figure out what's going on with your dizziness. Okay, and then we can begin. But she couldn't even reach her phone. So in doing an evaluation for her, she was obviously in distress and anxious, so I helped manage that first. Looking at her vitals, her heart rate was 108, blood pressure 92/56, respiratory rate of 20, pulse ox of 99%. That looks okay, right? But what do we know? We know physiologically she's vulnerable to a syncopal event. We know that blood pressure is already pretty low. That's probably what my blood pressure is now. So asking a patient, what is your baseline? And if they don't know, especially for someone during pregnancy, this is an amazing opportunity to educate them about how to self-manage. You should be checking your blood pressure, your heart rate regularly. There are so many ways to do that, right? And if you are seeing any patient and not assessing their vitals, I'd like you to reconsider that. So her fundal height is appropriate, no abnormal tenderness. We also know there's no vaginal bleeding or fluid leakage. I consider that outside of my scope. Okay, so Rebekah has a different scope than I do, and I'm fully aware of that. So I'm going to rely on my medical colleagues to help me with that. I'm still going to perform an abdominal exam just to make sure I'm not missing anything from a musculoskeletal perspective. But am I the one to assess how everything is going with the pregnancy? Probably not. And you have to understand your scope so you know what's in it and what's not. We also were able to find that she didn't have any real focal neural deficits other than a 4+ out of 5 in her right plantar flexion, otherwise 5 out of 5, normal reflexes, some diminished sensation in the L5 distribution. She also had a positive straight leg raise. So what are we thinking might be musculoskeletally going on with this patient? And if you are going to treat women who are expecting and postpartum, your musculoskeletal skills have got to be on point. We can't just have parts of our training that come in and out, right? So potentially a discogenic pathology here. Is that a big deal? Not really, right? Like it's not a huge deal. People have disc issues all the time, but how might it impact this patient specifically? Pain, function, and what's her goal? She wants to have a vaginal delivery. Might this complicate that? So when we're considering her plan of care, because we're not interventionalists, we're not technicians, we are people who manage our patients' healthcare and well-being, we need to keep that in back of mind. I can reassure her about that. This is not dangerous. This is pain that's hurting you, not damaging you, okay? It's safe to move with this pain. And there are options for us to get rid of that pain, okay? So her balance was a little bit off, nothing tremendous. She had some pain over her SI joint and her her right lateral hip. How are we going to manage that? What else do we need to look at that I haven't mentioned? We know what her vitals are. Maybe we might want to have her move and see what happens, right? So I will say that's absolutely crucial, and we have to do that with this patient, but I chose to manage her pain first because I thought the pain might impact her vitals with movement and not give me a good picture. Because if I'm truly suspicious of orthostasis, pain is going to do what to the blood pressure? It's going to drive it up a little bit. So it might actually be protective in this case. So I'm going to see if I can relieve her pain, reduce her nervous system overflow, and then kind of take a look at the orthostasis and what's going on. So what we almost missed in this patient, if we had discharged her, was presyncope and orthostasis. So by assessing vitals with mobility, we were able to diagnose that she did have orthostasis And it got progressively worse with movement. So she was referred back to the medical team for a syncopal workup. What we did to help manage her pain in the moment, we helped her regulate. We helped reassure her about her present and her future. Manual therapy. We put hands on this patient. Is manual therapy contraindicated in pregnancy? No. Are there some guardrails? Of course. But there's guardrails with every patient. And I had a conversation with a certain Rebekah Griffith about pregnant patients and how she would recommend that people treat pregnant patients when they come into the emergency department. And she was like, if you're treating them differently than any other patient because you're afraid of that condition, then you're doing your patients a disservice. So stop getting so hung up on red flags and remembering that everything is a spectrum and that you need to do what's best for that patient in the moment while making modifications for this condition just like you would any other. If I have a patient with a massive thoracic kyphosis, I'm not going to put them in supine and try and do the Dix Hall pike, right? Like that's not going to work. So for this patient, positioning her in side lying to help do manual therapy to reduce her pain, centralize those radicular symptoms, and help her find a position of comfort so she could rest. Okay? My goal is to get you out of the emergency department and to the next best step. But if you can't walk out, you can't go out. So making sure that she was able to relieve her own pain, have some relief from the anxiety, have some relief from the physical pain was really crucial for her. We also did some just soft tissue massage to help calm down the spasm associated with the fall. Finally, I was able to give her some nerve glides that gave her some good relief and move through that functional mobility progression while monitoring her vitals, okay? And going over lifting mechanics and all of those pieces that you would go over while getting her a referral for outpatient PT and getting her back to the physicians for a more medical workup. So I like to say that we are not just discharging our patients, we're equipping them. Because one of the worst things that can happen in an emergency department is that that patient comes back and they come back for the same thing. That's bad for your facility. It's bad for the patient. This is not where they need that care. Okay. So I need to make sure she's equipped to take care of herself. So we talked about what was the most likely cause of her syncope, and it seemed to be just pooling. So can we get you in compression? Can we talk about regular exercise? Can we talk about hydration? Can we look at your wellness wheel? Sleep, hydration, stress management, movement, and nutrition. If all of those spokes are not in alignment, the wheel doesn't turn. And people will say, I don't have time to discuss that with my patient, but if you don't, they will come back. And that's the difference between a home exercise program and a home management program. We're not giving home exercise programs anymore, okay? We are managing our patients. So my patient left equipped. She had the durable medical equipment that she needed, which coincidentally you can order as a therapist, both PT and OT in the state of Colorado. Thank you, advocacy. She left with a referral to see a physical therapist, a women's health specialist that would help get her to delivery and beyond. That's not my job, right? And she left going back for that medical workup so she had further reassurance that her health was intact and that this was a relatively normal complication of pregnancy, but it was one that could be managed at home. So a comprehensive management strategy, no matter which patients that you're seeing, if you're truly practicing at the top of your scope, they should be discharged and equipped. So my goal for my patients is that when they leave the emergency department, they're not just stable, they're able. Okay, we have to move beyond stability and move on to ability. So when we talk about what top of scope looks like, hopefully you're all like, that's it, right? Able, not just stable. We did it. We went above and beyond. We managed this patient really nicely. We used our full scope of practice. But top of scope doesn't stay still, and neither do we. So it expands with every single patient that challenges you and every barrier you push when you say this isn't good enough. So the top of scope piece that I want to leave you with is, what if she never had to come here at all? Where are we that this patient had to come to the emergency department to get this care? Where are we in that back pain's normal? It'll get better after you deliver. One of my children brought me migraines. He's 13. I still have those. But it was normal, right? Where are we in normalizing that pregnant women will fall? Like, why are we doing that? Why aren't we talking to pregnant women about how to support them with their body mechanics, their physiologic demands from the beginning of pregnancy through the end? And I push that even further and say before they are thinking about having children and what that lifestyle change will look like. There's so much that goes into that. And there are so many spaces that no one in healthcare will move into. But why are we not the right person to have seen this patient? Why was there not, say, a digital triage line where she could call and say, I fell. These are the symptoms that I'm having. Is this back pain normal? Where is our partnership with our OB/GYN providers and our midwives so that they know those patients can call us? That they don't have to have all those answers because we're the right provider at the right time to manage this within our scope of care. And that's why we talk about practicing at the top of our scope, because we haven't found the top of it yet. And we have to keep evolving to it. So with that, I'm happy to take any questions or if there's any discussion about that. But I want to leave you with what you're doing here today is really important. And it is top of scope work. So when you go back to your facility, just know that advocacy has to be the foundation of moving to the top of your scope. You aren't the limiting factor. It's accepting the status quo that's the limiting factor. And if we can't stand up and say the things, we're the right people to do this, and here's how we will do it, we're not going to move forward. And instead of people coming out of PT school and seeing jobs that are posted for them to work in this area of care, they'll take another job in acute care, discharging people home as quickly as possible, meeting unrecognizable productivity demands where they're not even allowed to make discharge recommendations. So we have to push at our facility, push at our license, and then push each one of us has an individual top of scope to move towards. So I appreciate you having me here today, even though this is not my area of expertise, and thank you for the work that you're doing.
Thank you.
You bet.
So I'm looking to start an acute care facility, like a program, and we have nothing. We're not doing obstetric. And I would like to have a little bit more your opinion. Financially, how do I have to plan this? How do I have to present this also to the administration to be sure that they have all the tools to help me to start that program?
Are they asking you for financial data?
They kind of did. I wanted to bring this there. So they and then they kind of said, well, you need to hire another PT? Would you need, like, they kind of say, well, how much will that impact us if you bring this program to us?
Right. So when you're thinking about any quality of improvement project, any kind of top of facility modification, I need you to look at the facility like a patient, right? So what are the impairments, functional limitations, and participation restrictions at your facility? You have the entire skill set. You have a doctorate in how to do this analysis. It's just different. And if you can analyze a human with all their unique individual needs, you can do the same thing with a facility. So what you need to ask them are, what are their barriers? What problems are they having? Because financial is probably not actually one of them. Most acute care demands are more around throughput than actual cost, because the throughput constraints are really one of the bigger issues. So for example, you have to ask them, what are your biggest limitations on this unit? So for example, if you have a C-section patient, if your C-section patients are discharging later than the normal, they're holding up a bed, so they can't get another expecting mother in that bed. So they're losing money there, and this is costing money because the C-section's most likely bundled payment. I don't know that for sure. So they want to get people out quickly and move the system through. The system doesn't work unless it's moving. So I would ask them what barriers they're having with throughput and what issues they have. They might also have a high fall number on that unit. Like, you don't know what their problems are. You have to do an examination and evaluation. So instead of going to the facility and saying, This is the financial data. They might not care about that. You need to figure out what they care about and then find that information. So I also recommend people usually do like a SWOT analysis. So what are the strengths of my unit? What are the weaknesses? What are the opportunities and the threats? There's obviously a massive space for opportunity, right? Because nothing exists there. And that's also one of their weaknesses, is they're not offering this service, which really should be standard of practice. But the threat is you might not have enough resources. You might have to hire another PT, but that's also an opportunity. So it's all in how you present it. But for example, if you're trying to get a PT in the emergency department, you have to know what metrics is your emergency department worried about, because that's the threat to them. So for example, they always think we're going to slow them down. That's what they're worried about. They're worried about how long it's going to take, not how much it's going to cost. They don't care about increased patient satisfaction. They don't care about increased provider satisfaction. They don't care how cool we are. They're focused on these numbers. These are their patient-centered goals. So what are the patient-centered goals of your facility in this unit of your hospital? And then show exactly how you'll address each one. So I wouldn't get hung up on what you think matters to them. I would find out what matters to them and then show them how you're going to fix that. And then once you get in there, do whatever you want. We went from having one PT on a pilot. There's now 3 full-time PTs and 1 OT every single day, 365 days a year. I mean, not on the weekends. There's 1 person, but you get my point. There's a presence there 365 days a year. And once you've shown your value, you'll be part of the algorithm. So that's the next step, is how do you implement your presence into their workflow? And you'll become so indispensable, they won't remember when they didn't have you. Does that make sense?
Yes.
But you can't get there unless it's meaningful to your patient. They're not going to do your home management program if it doesn't feel meaningful to them. Did you do your exercises? Well, I don't feel like they help. Do you want to go to physical therapy? No. Well, let me tell you why you want to go to physical therapy. In the emergency department, patients are much more likely to follow up to see an outpatient physical therapist if they saw a PT in the ED. It's like a Costco sample. You're here, you're only there to get what you want. You're there to get what you think you needed. And then you get the Costco lady sample and you're like, I do need dinosaur chicken nuggets. I need 150 pounds of dinosaur chicken nuggets. And so then they're way more likely to buy that again in the future. Purchase today and follow up with that. So you have to make it meaningful. So I don't have the answer to your financial data, but I do have the answer for how you should look at it.
Thank you. That's very helpful.
So Rebekah and Jenna and I met at an APTA Colorado conference. I had seen Rebekah's photo online as a highlighted Black provider of physical therapy services. And I was like, hey, I saw you. Do you see this photo? And she had no idea it was even out there. She was being celebrated as an outstanding Black physical therapist and had no idea. And I was so excited to meet her. I was like, look, is this you? And she was like, yeah, I did this at the bathroom door. I'm not going to lie. So awkward. But I was in my own growth journey about trying to introduce myself to people because I'm really bad at that. I know it doesn't seem like that, but I'm not good at that. So it was awkward because I am. And neither of us were really in our purpose at that time. And we had some very good conversations just that first day because we were both asking questions in this course. And it was like we picked up our heads and looked at each other. And we kept she would say something, I'd be like, right. And it kept going back and forth like that. So then we were able to talk about what is your purpose? What is your vision? And she's doing it. Yes. And you're here. Yes. And she and Jenna are transforming the world. So I want to thank you all for being here, for being part of that, and just recognizing that I've got to see the whole thing. And what a joy to see people pushing something into existence. So yeah, you can be a visionary without a plan. And if you're loud enough about it, other people will come and support your plan. So thank you for having me.
Thank you.